Good morning, everyone. How are you? Good morning.
Good morning, sir.
Good morning, sir.
Ganesh, good morning. How are you? Priyar, how are you? Can you hear me?
Yes, sir.
Hello. Yes. Okay. Can you see the slide?
Yes, sir. Slide is visible.
All right. All right. Priyar, where are you right now?
I am in Pokhara, sir.
You're in Pokhara. Lovely
Yes,
weather
sir.
in Pokhara. Bright sun. Very good. How far you are from? Priyar, how far you are from Deep Campus?
Just close to the campus, sir.
Just close only.
Yes, sir.
That's very good. That's very good. All good at your end? All right. All right. Sanskriti, good morning. Sanskriti, good morning.
Good morning, sir.
Had your breakfast?
Yes, sir.
What was the breakfast? Good, nutritious, full of fruits,
Yes, sir.
oats, parathas, egg
Aloo
and
paratha.
butter. All right. All right. Okay, we'll start slowly and slowly. Adhikari Ranju, you there? Adhikari,
Yes, sir.
where are you, Adhikari, right now?
Sir, it's Kathmandu.
Hmm?
Kathmandu.
Okay, okay. Okay, we'll start in a few minutes. On my screen, there are around 42 plus friends of yours who have joined me. Today we will be discussing the regional circulation. Regional circulation, what does it mean? Regional circulation simply means that there are special regions in the body where the circulation is special. And two or three of them, and I will mention. One is the cerebrum, or the brain. And second is the coronary. Just a minute. Please, sir. Very class, sir. Please, sir. Yeah. I thought I will check with some noise was surrounding. No problem. So. So one I said is special circulation, that cerebral circulation or the circulation of the brain. The second most important is the coronary circulation. You are aware the blood vessels which are supplying the heart. And then of course, few of them they are mentioned here, that is the cutaneous circulation, the skeletal muscle circulation, subplanchnic when we call it, that includes the liver, also kidney. We will talk today about the coronary circulation. All of you have had a lot many lectures on the cardiovascular system, and they have discussed in detail about the functions of the blood. We know that the blood carries lot many things, or when I say lot many things, I mean lot many things for the need of the tissues, tissues which are far away, far away from the center of the body. And to give you some examples, we know that oxygen is acquired in the lungs and transported in the blood. And this has been discussed in detail. We discussed about the hemoglobin, the functions of the hemoglobin, and oxygen is carried in combination with hemoglobin as oxyhemoglobin. Almost around 97% of the hemoglobin, all of you are aware, it's part of the RBCs, and RBCs are in nutrients from the GI tract, they are being absorbed. Not only the carbohydrates, proteins, and fats, but also the vitamins and minerals. And they are absorbed and carried in various forms in the blood for the nutrition or for the purposes of giving energy to various regions of the body. Third important thing you know about the blood is that it also transports hormones. And you are aware that hormones are substances which are secreted in the endocrine gland, and these hormones, they are poured into the blood to the various target organs. Say for example, thyroid stimulating hormone secreted by the anterior pituitary gland is carried in the blood to the target organ, that is the thyroid gland, and where it acts in synthesis of thyroxine or the thyroid hormones, which you are aware, T3, T4, so on and so forth. So one thing which comes to my mind is that heart is working hard, and its functions has been discussed in the cardiac cycle, and this organ helps to give nutrition to the various parts of the body. What gives it energy? Since it's a working organ, so naturally it must also get energy. And as for the other organs, the heart muscle itself needs oxygen for metabolic purposes, for its functioning. And that's oxygen we know only by the blood. And what carries blood to the heart are basically the coronary arteries. Coronary arteries take origin from the aorta, and if you can imagine the anatomy and physiology of the cardiovascular system, I'm sure you will be able to understand that coronary vessels' origin and its supply to the heart will be modified, number one, by the rate of the heart rate at which it is beating. Second, by the contractility of the heart muscle. And third, by the tension which it develops in the walls of the ventricles and the atria. And this has been beautifully described in the cardiac cycle, where it is shown two parts: systole, the heart contracts, and diastole, the heart relaxes. If we look at the total cardiac cycle timing, it works out to be 0.8 second. I had mentioned while discussing ECG also that various depolarization activities of the various, and there also we discussed that systole lasts for 0.3 seconds only, whereas the diastole lasts for 0.5 seconds. To emphasize, diastole or the rest period of the heart is much more, and it is basically during this diastole that amount of maximum amount of oxygen for its working purpose. Now let me go a bit into the detail. When we say coronary circulation, we said heart receives the blood supply. There are basically two coronary arteries. One is the left anterior descending. I think you can see it on this diagram also. There's the one which is the anterior descending branch, and the second is the circumflex branch of the left coronary artery. Now the left circumference branch, as you are seeing it, it supplies the left atrium as a whole. Left ventricle greater part, small part of the right ventricle. It's part of the interventricular septum is also supplied by the anterior descending by the circumflex branch, and bundle of his, you are aware, conducting system in the heart itself, that also is supplied by the circumflex branch. But what about the anterior descending? If you are looking at the anatomical structure here, you will see that it is basically in the region of the septum. So therefore, the anterior descending artery is supplying the septum as such. Right coronary artery we had just now seen here. It is supplying basically the major right part of the heart, and it has got branches cases which are known as the marginal branches. But when we look at the dominance, we see that a right artery in 50% of the cases is the dominant, and the left artery 20% of the cases, but it is equal in almost 30% of the cases. Now, what are the basic facts? Basic fact is there is a high resting blood flow. When I say high resting blood flow, that simply means when the heart is working normally. We know heart is beating at a rate of 72 beats per minute, and this rate is also set by the autorhythmic property of the heart muscle as well as the conducting system. There are specialized tissues in the heart, and some of them are SA node. SA node emits impulses at a rate of almost around 70 impulses per minute. The second one is the AV node. AV node emits impulses at a rate of 40 per minute. Which one is more? Actually, it is the SA node, which is much more. So therefore, SA node impulses, they predominate or they take over even the AV node. So that is why the heart follows the SA node, and hence it is beating at a rate of around 72 beats per minute. I said cardiac output is the heart rate into the stroke volume. This has been discussed earlier also. Heart rate you have understood right now. But what exactly is the stroke volume? If we look at the cardiac cycle, and when we see at the end diastolic volume, when the ventricles they are fully relaxed, how much blood is there in them? That is the end diastolic volume, which is around 130 ml. End diastolic, when the heart is fully relaxed. When the heart contracts, it pushes the blood into the aorta. The AV atrioventricular valves getting closed. The amount of blood which is pumped into the aorta per beat of the heart, that is known as the stroke volume. And how much it is? It is 70 ml. So when I say that the cardiac output is the total amount of blood which is pumped by the heart per minute, and that is equivalent to heart rate, that is 72, multiplied by stroke volume, that is 70 ml, and that works out to be around 4,900 ml, or say for all practical purposes, it is 5 liters. How much is the blood supply which is going to the heart itself? It is approximately 5% of the total cardiac output. And when I say 5%, that works out to be almost around 5%. 5 divided by 100 multiplied by 5,000. I think simple mathematics calculation, that works out to be around 250 ml. Important. Per minute. And when we work out, depending upon the tissue or the heart muscle weight, that works out to be 84 ml per 100 gram per minute. But I think for all practical purposes, you should remember that the blood flow to the heart is 5% of the total cardiac output, that is equivalent to 250 ml per minute, 250 ml per minute. At maximal cardiac work, maximal, when the heart is working under exercise, then naturally the blood flow will increase almost 3 to 4 times or so on. So if you are asked that what exactly are the basic facts regarding the coronary circulation, you will say that coronaries supply 5% of the total cardiac output to the heart. And that 5% works out to be 250 ml. Now, I said the cardiac cycle and the coronary blood flow. Let us try to understand. I will show you a little later, but first let us try to understand about the cardiac cycle once again. We know there is systole. Systole lasts for 0.3 seconds. And how much is the pressure during systole? And we know that pressure in the left ventricle has to be little higher than the aortic pressure. Then only the blood will move from the left ventricle into the aorta. So if we say that the force with which the heart contracts, force with which the heart contracts, that is actually the systolic blood pressure. And when we know the normal value of the systolic and diastolic blood pressure, we know that the systolic blood pressure is 120 millimeter of mercury. What does it mean? This simply means the force with which the heart is contracting. That is the systolic blood pressure. That means that is the pressure of the blood in the left ventricle. So let's say it's round on that 120. And this must be more than the aortic pressure, then only the blood will be pumped into the aorta. Go back to your books and look at the isovolumetric contraction and then ejection phase of the cardiac cycle. So for all practical purposes, if we say that the pressure in the left ventricle is around 1 millimeter higher than the aortic pressure, and similarly in the right ventricle the pressure is around 25 millimeter of mercury, and it is almost the difference is around minus 1 millimeter of mercury. If we say 121 is in the left ventricle, 120 is in the aorta, then the difference is minus 1, something like that. And when we look at the diastole, what exactly is this diastole? Diastole is the resistance which is offered by the elastic vessels as the blood is being pumped into the aorta and further downward. The resistance which is being offered, that also gives the pressure, and that is the diastole pressure, and that works out to be around 80 millimeter of mercury. So in the aorta, it is almost around 80 millimeter of mercury. In the left ventricle at that time, of course, it is 0. And same is true to the right and left, right ventricle as well as, and there the difference is almost around 80 millimeter of mercury. So what I mean to say is that these are the basic facts that number one, 5% of the total cardiac output is supplied to the heart muscle, and coronary blood flow varies with the cardiac cycle events, and coronary blood flow occurs only during diastole events when the heart is relaxed. Now let's take, for example, there is an isovolumetric contraction. Remember the cardiac cycle? Isovolumetric contraction. The time period is almost around 0.05 second. Now ventricular pressure rises. When the ventricular pressure rises, the intramyocardial vessels, that is the vessels within the myocardial muscle, they are compressed. So during isovolumetric contraction, the vessels are compressed, and therefore perfusion of blood is less. To an extent that during isovolumetric contraction, the coronary blood flow reaches almost 0 level. I hope I had made. I will just come and first listen to me, and I will just show you and explain to you once again, but go back when you are looking at the cardiac cycle. The second thing which I said to concentrate is the ejection phase, which lasts almost around 0.1 second. Now what is this ejection phase? When the blood is being pumped into the aorta, the aortic pressure sudden increase is there. So when the pressure in the aorta is increased, so therefore the coronary perfusion pressure will also increase, and hence there is an increase in the coronary blood flow. I hope that makes a little sense. Now, coming to the third phase of the cardiac cycle, that is the protodiastole, which is around 0.04 seconds. Now, the ventricles, there is a isovolumetric relaxation that lasts around 0.08 seconds. What is happening? Isovolumetric relaxation. There is a decreased ventricular pressure. And once the ventricular pressure is decreased, so naturally the blood vessels in it, they are minimally compressed. Or say it that intramyocardial compression of the blood vessels is minimal when there is a relaxation of the ventricles. When there is a relaxation, the aortic pressure also decreases to a level of around 80 millimeters of mercury. But the coronary perfusion pressure is fairly high at this level. So therefore, the coronary blood flow increases sharply, or the maximum coronary blood flow occur in the diastole. Let me see what is the next. Yeah. Here exactly it is the coronary blood flow and a relationship to the systole and the diastole, and we had said that the coronary blood flow occurs only during the diastole. Look at it. During systole, the coronary blood flow almost is coming to the minimal level, and during diastole, it is increasing. The maximum is occurring in the protodiastole stage. Why it is so? It is so, I had said that during systole there is a contraction of the heart musculature which secures the coronary vessels. So this effect is more in the deeper layers or the subendocardial. These are the subendocardial, but the diagram which is shown is that of diastole. But the effect of this systole is particularly more in the deeper layer than the subendocardial vessels than the superficial layer or the epicardial vessels, and this effect is maximum in the left ventricle. Therefore, the subendocardial surface of the heart is more prone to ischemia. I hope that makes sense. Coronary blood flow occurs during diastole. You have to remember this. The coronary blood flow occurs during diastole. Okay? Yeah. Here is what I have just now explained, and this is simply showing the coronary blood flow milliliter per minute per 100 gram, and here exactly is the aortic pressure which I had discussed. A here represents the isovolumetric contraction. B is the ejection, and C is the diastole. I hope some sense is being made by me, Priyar Ganesh. Hello.
Yes, sir.
Priyar Ganesh, you are there. I hope I am able to convey my thoughts and making the things a little easy for you to understand.
Yes, sir.
All right then. What do you say, Ronak Raj? Ronak Raj, you are hearing? Ronak Raj, you are there? Ronak Raj, you are there? No. You are left and gone.
Yes, sir.
Okay, okay, okay. What about Namika Sharif? You there?
Yes, sir.
I hope I am making a little easy and you are able to understand, Namika?
Yes, sir.
All right, all right. We will go slowly and we will proceed further. So I was telling you that how the coronary blood flow is affected in the various stages of the cardiac cycle. Now you see the importance of learning about the cardiac cycle. And we have said that if you look at this A, that is the isovolumetric contraction, and I have said during the isovolumetric contraction, the aortic pressure is almost to the tune of around 100 millimeter of mercury, and then there is a sudden rise in the ejection phase, that is to the tune of almost around 120 millimeter of mercury. And we had seen here down below that the coronary blood flow during the isovolumetric contraction has come down almost to zero because of the fact that the vessels in the myocardium, they are compressed when the muscles are contracted, and therefore the coronary blood flow is almost come to zero. And look at during ejection phase, and slowly and slowly the coronary blood flow is increasing, and during diastole the peak almost around 200 ml per minute. We said the total is around 250 ml per minute or so. So this is the time scale which we have said 0.8 second, that is the cardiac cycle. This is the coronary blood flow which is mentioned almost around 200 ml or so, and these are the aortic pressure, that making the things a little easy for you to understand. Now, we said that the blood flow to the subendocardial portion of the left ventricular during the diastole only. During the diastole only. If you look back at this diagram, this is the subendocardial portion, this is the diastole, and when the muscles are relaxed, so naturally the blood flow to this region is occurring only during the diastole. What is its clinical importance? I think that is what need to be understood. One is that if the diastole period is reduced, and how will the diastole period will be reduced? We know that the heart is beating at a rate of 72 beats per minute, and the cardiac cycle at this rate is 0.8 second. Now let's assume that the heart rate has suddenly increased to 200 beats per minute. When it has suddenly increased to 200 beats per minute, so naturally each beat does not get the enough time for diastole. And at a rate of almost around 200 beats per minute, the diastole comes down to 0.14 seconds from a normal of 0.5 seconds. So if diastole is less, so therefore the coronary flow will be less. Now, we have also seen that during No flow to the subendocardial part of the left ventricle. And that is why I have said that this region, the subendocardial part, I think this is here it is, subendocardial region, during systole, the vessels are compressed, there is no blood flow. So that is why this part is more prone to the ischemia or myocardial infarction. Now let us take another clinical situation. That clinical situation is aortic stenosis. What does this aortic stenosis means? Means that the aortic valves, they are stenosed or they are together joined, you can say. They are not elastic in nature, they are not flapping as such normally. So to push the blood into the aorta, the left ventricle pressure must rise much more. So what will happen when the left ventricular pressure is rising much more? During aortic stenosis, naturally the blood will be in the left ventricle, and left ventricle has to work with a maximum force. So therefore, the coronary supply to the left ventricle will be compressed as the ventricular pressure is increased. So therefore, during systole, if the coronary blood supply is reduced or is less, so during aortic stenosis, more chances of ischemia and myocardial infarction. Ischemia is simple anoxia of the muscle. Myocardial infarction is the damage to the tissues. Another corollary, that is during congestive cardiac failure. Naturally, same thing will happen. During congestive cardiac failure also, the venous pressure will increase and therefore the coronary blood flow will reduce. Now let's see ahead. Now, coronary blood flow. I think this is again emphasizing the same thing, that flow in the subendocardial vessels of the left ventricle occurs only during diastole. Look back at the diagram which I had shown in slide earlier. So, because diastole is shorter when the heart rate is high, I given you the example of 200 beats per minute and diastole coming down to 0.14 second from a normal of 0.5 second. The left ventricular coronary flow is reduced during tachycardia. This is a fact. Subendocardial portion of the left ventricle is more prone to ischemic damage. We had discussed that, and is the most common site of myocardial infarction. During stenotic aortic valves, I have just now discussed that blood flow to the left ventricle is decreased in these patients. Patients with aortic stenosis, therefore, they are more prone to develop ischemia and myocardial infarction. Increased venous pressure during congestive heart failure, I just now mentioned, it reduces the coronary blood flow because it decreases the effective coronary perfusion pressure. I hope so far so good. And then myocardial blood flow is characterized by almost complete oxygen extraction. That is maximum, around 70 to 80% of the oxygen from the blood is extracted for the functioning of the myocardium. Therefore, the blood flow must increase to increase the oxygen delivery, and hence the myocardial oxygen delivery is flow limited, and aortic pressure provides the driving force for the coronary blood flow. We have discussed it. When you look at the books of yours, I'm sure you will be able to understand it a bit better than now. All right. Before I go to the regulation of the blood flow, let me discuss one of the very important features in physiology, and that is known as conditioning. I'm sure you have heard about the Pavlov's experiments. You have read during the 10+2 science syllabus that dogs salivate. Normally, they will salivate when they look at the food, and I think we all are having that reflex. When a dinner is ready, the ma called us, the dinner is ready, and she has that you will get the dish of your choice, so naturally salivation starts. When you get the aroma of the food from the kitchen, the salivation starts. And this is all conditioning. Conditioning to the already known stimulus. But conditioned reflexes are when unknown stimulus is combined with the conditioned stimulus, that is the food. Some links are being established within our mind, and salivation occurs to the ringing of the bell. When ringing of the bell and the food presentation is repeatedly combined, and later on, when you are only ringing the bell, unconditioned, the dog starts salivating. A conditioned reflex has been established. What is the motive behind it of telling this story? In our day-to-day life, we are conditioned to the influence of many of our relatives, friends, and colleagues. And this influence is working as a conditioned reflex for us, and we are unable to break this chain. To give you a story, once a gentleman was passing nearer the elephants' herd, where they were kept tied with a very small rope. He asked the trainer of the elephants that such big animals, why don't they just pull it and go away? He said, "Sir, when they were born, we used to tie them with this same rope. And as they are grown up, they have become conditioned that they are unable to break this rope. So therefore, they cannot go away. Moral of the story, we must shed the shackles which are surrounding us by the influence of the society, and therefore make ourselves free to achieve the highest possibilities which all of us desire. It is within us. We can do it. Everyone can do it. At any age, it can be done. Let us free ourselves from the conditioning powers of the surrounding environment. Moral of the story. Anyway, regulation of the blood flow, and this regulation is by the metabolic or functional or hyperemia, and there's a reactive hyperemia, and there's an auto-regulation. What do we mean that heart muscle? As I said, the maximum oxygen consumption is at rest, and more the metabolism, therefore more will be the need of the coronary blood flow. So therefore, auto-regulation. And this auto-regulation can come by two factors. One is the chemical factor and second is the neural factor. Let me first describe the chemical factor. What is this chemical factor? Chemical factor is nothing but ischemia of the muscles because of lack of oxygen or because of hypoxia. Ischemia of the muscles because of hypoxia, because of lack of oxygen. And this is what is also known as the Berne hypothesis. Now, Berne hypothesis states that ischemia of the muscles or hypoxia or increased metabolism when metabolism or the metabolic rate is high, naturally more and more oxygen is being consumed, therefore hypoxia. Now this hypoxia can lead on to intracellular, that is the myocardium cells, intracellular breakdown of the substance that is adenine nucleotide. Adenine nucleotide into adenosine. And this adenosine enters into the extracellular fluid, and adenosine is one of the potent coronary vasodilator, and therefore increase coronary blood flow. So chemical nature, auto-regulation means hypoxia. Hypoxia, breakdown of adenine nucleotide into adenosine. Adenosine leaves the muscle cells, enter the extracellular fluid, and it is a potent coronary vasodilator. So this is what is known as Wernicke hypothesis. And that simply means once adenosine is released, it's a potent vasodilator, it causes vasodilatation, therefore the hypoxia is relieved. Autoregulation. Now extracellular fluid, adenosine, more and more blood flow. So therefore the adenosine which was released in the extracellular fluid, that is washed away, and coronary blood flow is regulated. There are other vasodilator metabolites which are acting locally, and some of them you are aware: carbon dioxide, number 1, H ions, number 2, potassium, number 3, lactic acid, also prostaglandins, and I had mentioned adenosine, adenine nucleotide. All these, they can increase the coronary blood flow. There's another version of this. This is just for interest only. I said that the Burney hypothesis, myocardial hypoxia, that leads down to breakdown of adenine nucleotide, therefore adenosine, and therefore vasodilatation. Actually speaking, ATP and ADP, they are 4 times potent vasodilators vis-a-vis adenosine or adenosine monophosphate. But the question is that the ATP and ADP, they cannot cross the myocardial cell membrane. As I have said that the adenosine can cross it and enter into the extracellular fluid. So therefore, causing of vasodilatation of the coronaries is not. I'm talking about the ATP and ADP. They cannot cross the myocardial cell membrane vis-a-vis the adenosine, which easily passes through the cell membrane. So the Burney principle, hypoxia, adenosine, increased coronary blood flow. The second is that if at all the coronary artery is blocked and then you release it, there will be reactive hyperemia. And we had seen that denervated as well as intact hearts. When I say denervated, when the heart nerve supply is cut. And when we give intracoronary injection of cyanide, 1, or when there is asphyxia, or when there is hypoxia, all these lead to increased coronary blood flow. Neural factors, they are important, which I will discuss tomorrow, and I think we will leave it for the time being here only. I hope you had enjoyed this lecture. You kindly go through the book, and I'm sure you should be able to understand it better now. I will leave it here, but hold on till such time I download your